Hello everyone, welcome to today's webinar. My name is Michael, and in a few moments I'll be passing the stage over to Helen to talk about our subject today of topical medications. But first, a little bit of housekeeping. As normal, this webinar is designed for those who have a little bit of medication background or knowledge, and is designed to help you understand your role a little bit further. Secondly, if you do have any questions as we're going through the webinar, please feel free to ask using the Q&A section on the webinar. There was a little bit of delay between us and you, so we'll be answering all the questions we get at the very end. But now I'm going to pass it over to Helen, who will tell you a little bit about herself, and we'll move on with the...
Hi, thank you. Hi, thank you, Michael. Hi, and thank you everyone for joining today's webinar. For those of you that don't know me, I've worked for PrimeLife for 4 years, and I'm involved in everything medication, including developing new training packages, audits and email. Previously to my joining PrimeLife, I worked for several pharmacies, supporting care homes all over the country. I think of myself as a people person, and I hope you find this webinar today a useful support tool. So let's begin. Today we're going to be looking at topical medications, and this session has been requested by one of our homes. We will be covering today infection control, gloves and hand washing, the difference between a cream and an ointment, applying cream, FTUs, fire hazards and storage of creams, and demonstration. So when should we wear gloves? There's a lot of confusion out there, but is there any evidence when we should wear gloves for medications? We should always refer to the WHO glove use. The World Health Organization has a leaflet on glove use, and you can find this leaflet at www.who.int/GPSE/5May/glove use information leaflet, and you can print this off and put it in as a PDF, and you can put it in with your medication information. It's really a useful, informative piece of information there. So when do we use gloves in our care settings? Well, we don't wear gloves for oral medications or for applying patches. We don't use gloves for eye and ear care unless secretions are present. And when I mean secretions, I don't just mean tears, I mean that there's actual infections in the eyes, because one of the things we don't want to do is transfer that infection to someone else. But we always wear gloves when we're applying creams or any sort of topical medication. When we're talking about wearing gloves, I get asked a lot of times, what about drug absorption? So yes, we use gloves for topical medication, as I said, and if you know the medication will cause an irritation to you personally. We can wear gloves even if there's no need to wear gloves, even if we're touching uncoated tablets. Sorry, we should wear gloves if we're touching uncoated tablets. An example of this is methotrexate for arthritis and psoriasis, and this is COSH, just being ultra cautious. As you're aware, most medications are coated, so you don't actually touch the drug. And even if you're handling an uncoated tablet, the drug would need to be in contact with the skin for hours to be absorbed. Obviously, during our medication rounds, we use the no-touch technique, so we should pop straight from the packet into the Medipot. Infection control. So now we've discussed when gloves should be used, let's discuss when it's appropriate to wash our hands. So before preparing medications, we should use the hand gel on the trolleys, and we should use that after administering medications to each resident. So every time we've administered a medication, hand gel on before we administer another medication. After administrating the medication round, it's always best to clean the trolley down and obviously to wash our hands. And obviously, of course, if we should spill or splash any liquid or topical medication onto our skin, lock the trolley up safely, wash your hands, and then start again. So again, I get asked a lot of times, what's the difference between a cream and an ointment? And when is the best to use either one or the other? So let's have a look at creams first of all. In general, residents prefer using creams to ointments as they're less sticky and heavy on the skin. Even though we think of creams as being moisturising, given their higher water content and the evaporation that occurs following an application, creams are better than ointments for treating oozy or wet skin conditions, since the porosity or thickness of creams is less than that of ointments, so they work better for covering large areas of skin. Ointments, on the other hand, are best to be used on dry skin. They are occlusive, which means they trap the moisture and are not well absorbed into the skin. Therefore, they can keep the skin moist for longer periods of time. Ointments also promote more complete absorption of the active ingredient or medication. Because of the preservatives used in creams, ointments are less likely to cause an allergic reaction. So if you do have a resident that reacts to some topical products, it may be as well to speak to the GP and get them to prescribe that medication in an ointment form. Here are some rough bullet points or guides between ointments and creams. So as I previously said, creams are best used when covering large areas of skin or to avoid the greasiness associated with an ointment. Wet or weeping skin lesions such as eczema or poison ivy are best treated with a cream or in fact a gel. Ointments are best when treating dry skin conditions such as psoriasis. And ointments allow greater penetration of the active ingredient in the topical medication, whether it is an antibiotic, steroid, or an antifungal medication. The best moisturisers are in ointment form. Ointments may be better to use on sensitive skin, since many creams are manufactured with sanitising preservatives. This slide just shows us a tub of aqueous cream, and it's something that you probably see a lot of in your care settings. And about 50% of people, aqueous cream can actually cause itching and irritation, and it can also thin the skin. Now, this is something, as I said before, we see a lot in our care homes, and we tend to apply this liberally. But just be aware, you know, if the resident does start scratching or itching into the skin, it could be they're having a reaction to the aqueous cream. How much to apply? So there's different rules on how much of the topical creams we apply, and the products on the screen today now. You should always apply sparingly or thinly. So we're looking at all ointments, barrier products, and some medication topical creams as well. When we're looking at moisturising creams, and again, these are examples on the screen like Dipivase and E45, we should apply this generously or thickly over the skin, and a layer of the cream should be seen sitting on this skin, because what will happen is this cream will be absorbed through the skin and through the barriers of the skin, making the skin less dry. So what does apply sparingly look like? So sometimes some of our staff have asked me, well, what's the difference between sparingly and thickly and thinly? And so when we're applying a cream thinly or sparingly, you should be able to see the skin through the product. There's either no visible product on the skin or just a little. And non-medicated ointments, a thin layer or a thicker layer if it's really dry. But the main rule of thumb is you should be able to see the skin through the product. Another question I get asked is when the doctor sometimes says apply an FTU, and we've had this question raised several times. What is an FTU? Well, that's a fingertip unit, and it is for most steroid based products, and the recommended fingertip unit will depend on which part of the body is being treated. So the fingertip unit goes from the top of the finger to the first crack. Okay, you rub your hands together and that should be enough to apply over certain parts of the body. If it says 2 fingertip units, you would do 1 and then measure the other. Okay. We do have just a little bit to add on that. We do have a fingertip unit chart that is available for any staff that are unsure on how much to apply. And again, now we're just going to have a quick refresh about barrier creams. So barrier creams, the most typical one that we see in our care settings is Sudocrem. And we apply this thinly so we can see the skin through the cream. Otherwise, we get a build-up. Now, what this means, it means that the resident can become very uncomfortable because it takes so much soap and scrubbing, if that's the right word, to remove this cream from the skin. It can also cause irritation, and too much can affect the incontinence pad, so it can affect the stickiness and the absorbency of an incontinence pad. And if our residents are getting this applied on the stomach or the bum or the top of the legs, obviously this is going to affect those and can cause some discomfort for them. So please remember, Sudocrem is a barrier cream and we apply that thinly. And again, just a few notes on how to apply. So again, we would stroke it down the limb if the person is hairy. We do this because otherwise you can backcomb the hair, which can feel uncomfortable. Don't even bother trying to rub this in. It won't achieve anything and might irritate the skin. So again, a lot of our residents have very frail skin. We shouldn't be rubbing it in. We should be dotting it on the hand or on where it is. So you apply the cream in dots and then you gently massage that into the skin. Stroke it towards the heart if applying to the legs, because this will aid circulation. So ointments are 80% to 100% oil, and you only need a really thin layer of this. There's less need for preservatives in ointments, and therefore there's a less risk of skin irritation. Often people don't like these because they're greasy. And one thing to remember is this is an ointment. It sometimes can be very highly inflammable, so be careful if it's getting absorbed into clothing or into the resident's bedding. And again, be careful if you're applying it to the face and you're a smoker, because again, if you're applying it to the lips and you're having a cigarette, it could quite easily cause some quite serious damage. So just a little bit of care on that. So the storage of external preparations or creams. So all external medications like creams, ointments, shampoos, bath preparations should always be stored securely in a locked cupboard, separate from all internal medications. Now, this doesn't always necessarily mean that we need a separate cupboard for them. In some of our homes, the excess cupboard, which we don't like to have too many things in there, we have one side or a shelf just for our medications and another side or a shelf just for creams and topicals. And as long as they're clearly labelled and they're not mixed, that's fine. CQC guidelines state that creams can be stored in a resident's room, but safe storage, secure storage must be available. And the residents should be consulted to make sure they're happy for the products to be kept in their room. One thing that we need to consider on this is some of our residents walk about, they walk into other residents' rooms. If we leave a tub of cream or shampoo or anything that's an external product, there is a risk involved that the resident could pick up that product and try to either eat or drink it. So again, after using the products, always put them away securely. Always remember that we should not be stored on the window ledges or elsewhere where the temperature reaches 25 degrees. So again, you know, during the summer we've had some lovely days with the sun shining, and we all know that our care homes can get really warm. Don't put the creams in the window because it will distribute their products, and it won't be nice to apply. In some cases, creams such as Topical cream need to be stored in the refrigerated temperatures, so these are not suitable to be stored in a resident's room. Care should be taken not to administer the cream straight onto the skin from the fridge. So before applying the Topical or any cream that's kept in the fridge, take it out, just leave it for a little bit before applying. And again, when the pharmacy delivers these for you, they should have a fridge label attached to them to make it quite clear where they are stored. Just a little bit about fire hazards. So again, most of our skin products contain paraffin-based products, for example, white soft paraffin. And again, this should have a fire hazard warning on it. And again, there has been in 2001, which is quite a while ago, but there was a few incidents of residents having suffered serious burns. And in 2006, a patient died. And this is obviously because some of the products could have gone onto their clothing, as we said before, or could have gone onto their bedding. They've been near to a heater or they've lit a cigarette. And obviously the clothing has had this product on. It's caused it to be flammable. So sometimes residents will refuse to take their medication. It could be because the medication is hard to swallow or tastes unpleasant or causes side effects such as loose stools or constipation. And again, this can apply with creams and topical medications as well. Our residents will refuse them because they don't like the feel of them on the skin, or it makes them feel sticky and sweaty. You can usually tell from the person's reaction that they dislike the taste or they dislike the medication being applied, or that the drugs can cause unpleasant side effects. And always contact the GP for advice on alternatives. It could be that the creams are too thick for them, they would prefer an ointment, or vice versa. And there are times when a person is more comfortable taking the medication in a particular setting or with the help of a certain member of staff. Think dignity and respect when you're administrating medications to your residents. Now, when I'm out and about on my travels pre-COVID, I did see a lot of residents having their creams applied in the dining room at lunchtime, along with eye drops. And I always checked with the member of staff that they actually had the consent of the residents to apply the creams in front of everybody else. I would always recommend that applying creams is a very personal nature, and the resident should be in their own room. But again, it could be the resident's choice, so we need to document that. If the resident refuses the medication, we can offer the medication later, but this must be documented with the exact time on the MAR chart and does not apply to time-critical medications. Remember, the resident has the right to refuse. And it is really important that we document if a cream hasn't been applied or has been applied, because then if it's not been applied and we've not documented it and the symptoms get worse, you know, we could see, well, that's the reason why. But if we don't document it, then we don't know. And if the resident is refusing to have that cream applied, then we need to look at alternatives from the GP. As we know, it's always important to remember to document on the reverse of the MAR chart any results or outcomes if the medication is a PRN or when required medication. And for those homes now using the EMAR system, there is an option on there to go back and complete a follow-up and to document the outcomes. This next statement doesn't really apply to creams, but don't be tempted to hide medication in food, because medication that's hidden in food is called covert medication and needs to be approved and have written consent in place. This should be documented in the care plan and documented on the MAR chart. And always think about your MCA and dose training when administering these medications. Does the person have the capacity to refuse to take their medication? If they refuse it, try again later, and remember to document and report all non-administered medications and inform the manager. If the medication is refused throughout the day, talk calmly to the resident, explaining the importance of taking the medication and how it will help them before documenting it as refused. Remember, documenting all non-administered medications, including creams, on the MAR chart is just as important as documenting when a medication is being given, as this information could be important later. Always remember to wash your hands before and after administrating any medications, and always use the appropriate PPE. Remember to clean the medication trolley before and after each medication round, replenish the medipots, giving spins and syringes, and always think about your infection control training, especially when you're applying creams to our residents. Just a little bit more of additional information. So always ensure that topical administrations are documented on the body map. This is to provide an audit and make sure it's on the right route. Remember your dignity and respect training. Always add the date of opening to the product to ensure that it's used by the expiry date. Check when where the product should be used to ensure that the product is stored safely and can be carried forward. Store topical medications separately from liquids and tablets. And again, we talked about this earlier, it doesn't need to be stored at the other end of the room. It can be in the same cupboard, but it must be clearly divided. Always check the manufacturer's guidelines and carry forward the item to next month if recommended. And we do this to reduce our waste. Remember that most topical medications are highly inflammable, and there's usually a warning, a fire hazard warning on them to warn you to take extreme care. Medication side effects. So all the medications discussed have side effects, including headache, constipation, diarrhea, rashes and sores. And the rashes and sores and irritated skin are more appropriate to the medication that we've been talking about today. Always monitor these changes and document them and report them to your manager. But to find out more about the medication, check the patient information leaflet in the medication box or the BNF, or look on the EMC website for any side effects, dosage information and overall advice. And for those of you that are using the email system, the BNF is available on your homepage, so please use that. And you can download any patient information leaflets off that site as well. You should always check the patient information leaflet in the medication books for any side effects and medication advice. And a thing to always remember is always inform the supplying doctor or pharmacist if the resident is taking any other medications, including herbal medications, vitamins or supplements, cold and flu preparations, homely remedies, any creams or ointments that their relatives may bring. And remember that if the resident has any allergies, this must be documented on the MAR chart. It's not just an allergy to medication, it could also be allergy to fruit, vegetable, nuts and things like that, and a lot of these can be found in some cream preparations. So that's me done for today. Michael, do we have any questions?
Okay, so how do I document creams? Should it be on the mar chart or the body map, and what details do I need to add?
Okay, so the booking in of the cream should be on the mar chart, and any medication that has been refused, if it's a medicated product, so if it's got a pharmacy label or sign on it, then we need to document that on the mar chart. So for example, if it's a steroid cream, we would document that on the mar chart. If it's a cream that the carers apply when the residents are getting dressed or before and after showering or whatever, a lot of our homes use body maps, which are in the residents' rooms. Now, this should be filled in every time the cream has been applied. And what we need to put on there, whether it's on the mar chart or on the body map, we need to put the frequency of use. So how often are we applying that cream? The thickness of the application. So again, is it applied sparingly, or do we apply a thick layer to it? And where on the body the cream should be applied. So again, is it, you know, just areas of the body? Is it the whole body? Is it the face? And what we like to see on the body map is an image of the cream or topical preparation. We need to see the dosage, we need to see the time when it's applied, but we also like to see the areas on the body actually marked where the cream is going to be applied. So it's really nice and clear for any new care staff going in, they can see exactly where that cream is to be used.
Okay, perfect. Do I carry forward creams from month to month? So if one's just been recently opened, or do we have to return them to the pharmacy?
Creams should be carried forward until their expiry date. So we have these big tubs of Dipper Base cream, E45 and so forth. They've all got the manufacturer's use by date on them. We should adhere by that. So we shouldn't be returning these. We should be carrying forward every month, and we shouldn't be returning them. With most of the creams in the tubs now are of a pump dispenser. So we're not actually physically putting our fingers or hands in it anymore. And again, we should always document the day that it was opened, and it is good practice to document on a steroid cream, especially the day that we need to stop that cream. So if it's just for a short course, that should be documented on the mar chart, but I would also put the opening date and the expiry date on the product as well, and on the body map. So the more information that we put on the product, on the mar chart and on the body map, then we can check all these three things together.
Okay, so sorry, is that a case of then if once we hit the expiry date or the use by date, we return it to the pharmacy at that point?
Absolutely, absolutely, yes.
Perfect.
And the expiry date is the date that's on the product, not on the pharmacy label.
Yeah, okay. The last question we've had come through is, if I am doing the medications round, but another carer is applying the cream, who is meant to fill in the mar chart for that process?
Okay, that's the one we always get asked as well, because obviously when our senior staff are doing the med round, a lot of carers will be applying the Dipper Base or aqueous cream or whatever. So the rule of thumb is if you didn't apply it, you don't sign for it. What I would advise is putting on the paper mar chart or on the EMAR system applied by carers, and then have a body map in the residence room that the carer needs to sign daily. Now, at the end of the week, I would recommend that either the senior or the home manager checks that these body charts in the residence rooms are actually being signed, so then we can progress and see how the soreness or the irritation or the rash is progressing. But if the top and bottom of this, if you're not applying, you don't sign the mar chart.
So simple case of if you didn't do it, you don't sign it.
No.
Perfect. Well, that's all we've had today then. So
Thank you, Michael.
thank you everyone very much for watching. Helen, if they do have any more questions, how can they contact you?
Yeah, sure, Michael. They can contact me on my email, which is helenberridge@prime-life.co.uk, or they can just give me a call on 07917 045 483.
Perfect. Well, as we said, thank you everyone for watching, and we'll see you again in 2 weeks' time.
Thank you, Michael. Thanks, everyone. Bye.